incredibly happy to be here with you all today to discuss a really important topic of epilepsy. And our team that we have here today are really amazing to be able to talk about this topic, as well as what we've learned over the past few years. And so for myself, as was mentioned before, so I am Tony Fuller, and I'm the Associate Director for DGNN. And looks like, are there audio issues again?
Yeah, I'm not sure why. It was great for a while.
I apologize. Maybe someone else can go, and I need to fix my audio then.
Tony, do you have perhaps a different computer? Because it sounds like a microphone problem.
It's the microphone is coming from my headphones, so it's definitely not that.
Now it's better. Want to give it another try?
Okay. This is funny. I've been in meetings all day with no problems until this one. All right. So yes, Associate Director for Duke Global Neurosurgery and Neurology. And what I wanted to do is, for my side of this, just share a little bit of our journey. So Duke Global Neurosurgery and Neurology began back in 2014. And a lot of our work, again, I'm seeing shaking head. Okay, can someone else go, honestly, because I'm going to need to log off and fix my audio.
Yeah, let's go to Dirk. Do you feel comfortable giving this a start?
Yes, but I can't give you an introduction to DGNN, and maybe Debra should pitch in now, although you've respectfully asked to come in a later position. But I suppose that you can better provide to the audience why we are around on this call and why we're talking about Uganda, and then maybe Angelina can pitch in.
Sure. Hi, everyone. My name is Debra Coltei, and I'm the director of the epilepsy and neuropsychology programs in DGNN. As introduced, that's the Division of Global Neurosurgery and Neurology at Duke. DGNN has had a presence in Uganda, Africa for about 10 years. Tony surely later on will tell us precisely how long, but they have been the group has been instrumental in building capacity and forming a joint training program in neurosurgery for several years, and has done a lot of scholarly work around the need for neurosurgery and surgical capacity in Uganda. So prior to our initiating our epilepsy work, DGNN already had established a lot of important collaborations in the country. And so when we were joined and supported by UCB's societal Division of Societal Responsibility, which Dirk will talk about a little bit later, we were able to expand our commitment to infrastructure building into the epilepsy area. And our leader, Dr. Hagland, who is the leader of the neurosurgical capacity and training program there, also has a lot of experience in epilepsy neurosurgical care. And so he was the one that moved our DGNN efforts into epilepsy care with the support of UCB. And our work there has, we started by reaching out to the scholars already in the country, and we're going to hear from Dr. Kakusa, who is one of the leading epilepsy experts in Uganda. And then we also made connections with other neurologists and psychiatrists in the area. And we collaboratively began a number of studies to better understand epilepsy care in Uganda and the cultural context of that care. And Tony is back, I hear. I got a little bit of a message. So I'm going to put the rest of my part on hold, put a pin in it, and ask Tony to come back and set the context for us a little bit more. And then later on, we'll talk about the studies and the cultural context of epilepsy care when I return. Tony?
Yes, thank you. So apologies for that, everyone. Is my audio clear now? Okay.
That's great.
Too many too many things going on at once, apparently. So I think Debra's already done an excellent job of setting up how we initially got into doing neurology work, but then specifically into epilepsy. And so what I wanted to share on this side of things is really part of the beginning portion of this, which is really fundamental to how DGNN as a group approaches our work. And so one of the key facets is that anytime we are wanting to approach a topic, the one key thing is ensuring that we have communication with the stakeholders on the ground. And so part of our initial approach was trying to find everyone who did work in Uganda on epilepsy. And so one of the first people we encountered was Dr. Angelina Kakusa, who is certainly an all-star in this area and is one of the biggest names in this space. And so we were incredibly happy to be able to communicate with her. And then, as Deb mentioned, that really allowed us to then also branch out to all of the other neurologists that are doing work in the country, the psychiatrists who are also doing work in the country. Important to note is that in the context of Uganda, epilepsy is seen as a mental health condition, and therefore it's under the mental health division that a lot of patients get cared for. And so that's why we also began some of our collaborations with psychiatry, and then also other folks who are doing this work. And so we wanted to communicate with the societies throughout the country who were interfacing with the epilepsy community. So the Epilepsy Association of Uganda, as well as other organizations that are trying to reduce the stigma. So one such organization is Purple Bench, which focuses on educating and exposing young kids to epilepsy. And so this was our initial approach, is trying to make a lot of those communications in order to ensure what are we planning to do moving forward, and which is the same thing that we had initially worked on as we approached neurosurgery development. From that initial conversations, there was a few things that we really wanted to be able to do. We wanted to be able to understand what were the futures. So what does the next 5 to 10 years of epilepsy care in Uganda look like? And initially, some of the conversations came down to how we need to understand what are some of the current barriers of accessing care. What is the current actual number of patients in the country that actually have epilepsy? And then what are some of the strategies that'll be incredibly important for that developmental process? So being able to understand, where do we need to invest in clinics? Do we need to invest in educating first-line healthcare workers? What are the most appropriate steps, which really led into our research? And I'm not going to dive into that too much, but we'll just wanted to set the stage for that. I was also given one task of ensuring that we all know what epilepsy is. And so I just wanted to briefly touch on that, and then I'll pass it off for the rest of the introduction. So just to make sure we're all on the same page, epilepsy is actually a categorization of a bunch of different things. So epilepsy is not a single disease. Epilepsy is just someone who has had repeated seizures. And so, as most people may know, a seizure is actually when there's some type of electrical malfunctioning in your brain that either stays focal and causes a very focal seizure, or generalizes to the rest of your brain and can cause a generalized seizure. Now, within this area, there are lots of different categorizations. So epilepsy is not a single thing. Therefore, this is why it's also very difficult, one, to diagnose, and then two, to treat appropriately, because you also need to understand what are actually causing the person's seizures and what type of possible epilepsy syndrome do they have. And just a little bit about, so this is the context and what's most important about epilepsy, and I'm going to share my screen briefly. What's most important about epilepsy is that it has a very large impact. And so there's about 50 million people that are living with epilepsy around the world. And most importantly, to our point today, is that about 80% of those people live in low and middle income countries. And what's unfortunate about the situation is that in those areas, about 75% of these patients aren't able to get treatment. And some of those causes have to do with things that have already been mentioned in terms of lack of staff, lack of access. And this really leads to greater risk of premature death from epilepsy, as well as the stigmatization and discrimination that happens with people who have repeated seizures. So all of these are the contexts with which our team went into this collaboration to figure out how do we address and how do we approach epilepsy, specifically in Uganda. And so with that, I will pass it off. And that was my introduction, and then what our team is doing. And again, apologies for the audio connectivity issues.
Thank you, Tony. I think we'll go next to Angelina. Angelina, if you're ready, as a quick backgrounder, Angelina Kakusa is a physician and a senior lecturer and child neurologist in the Department of Pediatrics and Child Health at Mbarara University in Kampala, Uganda. She also manages the Pediatric Neurology and Epilepsy Clinic in Malago National Referral Hospital in Kampala, as well as leads the inpatient pediatric neurology ward in the same hospital. There are about 100 other introductions we could make on Dr. Kakusa, but I'm going to let her take it from here.
Thank you very much for that introduction. Can you hear me clearly? Okay. As she mentioned, I work in Uganda, and I'd just like to, before I start, I always like to take advantage to talk about my country because it's an opportunity. I come from an East African country, which was named the Pearl of Africa by Sir Winston Churchill. We actually have quite a lot of flora and fauna. You can see those chimpanzees and rhinos, and we have quite a rich array of wildlife. I'd like to encourage you who are interested in global health to take the leap and come to Uganda and see, yes, there is science, but there's also a lot of tourism that you can do. And you know from your geography that we have the River Nile. The source is in our country. They claim that John Huntington's Peak was the one who discovered it, but definitely there were people, locals around the area who had seen this, source of the Nile before him. And we know that in the Nile, there's a lot of fun. You can come and do whitewater rafting if that is something that you can be able to handle. So back to the question of why I'm here. I work in a place called Mulago National Referral Hospital, which is situated in the capital city, Kampala. And this National Referral Hospital is a university teaching hospital, which is specialized in tertiary health care. It trains health workers and also conducts research. This hospital is attached to the Makerere University College of Health Sciences. And Makerere, for your information, is one of the oldest and most prestigious universities in Africa, founded in 1922. So our site for training our doctors to be is in this hospital, and we have a vast array of patient structure. We have the very poor and the very rich, with a diverse socio-economic clientele broadly. I do a lot of several things. One of the things I do is I'm in charge of the pediatric neurology inpatient ward, in which I see children with all sorts of conditions that can make them be admitted. Commonly, we see malaria with seizures, meningitis. We see children with cerebral palsy, children who have cerebral palsy with another complication, maybe aspiration pneumonia, to mention but a few. I also do an emergency call in an acute care unit, an emergency unit, twice every month, and also teach post and undergraduate medical students and also paramedical students at the university. And in addition to that, we have to go into the community, teach mothers and caregivers about various topical pediatric issues in the community. And I also run a specialist neurology clinic, as has been mentioned by Mary, once a week. But this clinic, we're trying to expand and also have it twice in a week. And in this clinic, I take care of individuals with various neurological conditions, as shown on the slide. But my main passion actually is doing research. And I do research on neurodevelopmental disorders, that is epilepsy, cerebral palsy, and also autism. And it's because of this research that I came in contact with researchers from Duke, and we were able to collaborate on the studies that we're going to be elaborating about. So that's me in a nutshell. We shall be able to talk more later. Thank you.
Thank you for that presentation. Next we have Dirk Tuan. a global head of medical sustainability at UCB in Brussels, Belgium. He does research in pediatrics, epilepsy, and public health. As global head medical sustainability at UCB, he also directs the design, development, and implementation of selected sustainable strategies in several epilepsy initiatives in different African and Asian countries. And Dirk has worked around the world and has an amazing background. So Dirk, tell us a little bit more about yourself.
Well, thank you for joining this call. And I'm a physician by training. I graduated at the Catholic University of Leuven in Belgium and worked in industry since I graduated. And in the past 10 years, I've been working for a company called UCB in the Societal Responsibility or Medical Sustainability Department, leading initiatives on epilepsy in various countries in Africa and in the Far East. We have reached out to partners such as Duke University in order to understand on how we can contribute as a company, financially as well as in kind, to improve the care for patients living with epilepsy or with neurological conditions. And we have been very fortunate to come in contact with the team of Duke and with the team in Uganda under the leadership of Angelina, because it is a very strong pillar of epilepsy surveys and research activities in Africa. Africa, as you remember from the slide of Tony, about 80% of the people with epilepsy live in low and middle income countries, and they have an extraordinary high prevalence of the disease when compared to the countries where we live in, like Belgium or the United States. And in order to have a good understanding, it's important to do prevalence study to know what is the burden of disease, and then tailor your interventions at what Angelina was saying, community level, at healthcare level, at academic level, and at public policy level. And I'll stop here because otherwise we'll go on too long. Thank you.
Thank you so much. We're going to return to Deb, who pitch hit at the beginning. Thank you again for doing that. Debra Coltei is a tenured professor in psychiatry and behavioral sciences with joint appointments in Duke's Department of Neurology, where she directs the Duke Clinical Neuropsychology Service and the Department of Neurosurgery. We're in the Division of Global Neurosurgery and Neurology. She also directs the epilepsy program. And I'll let you take it from here.
Thank you. So it's, I'll just start by saying that this part of my work as at Duke is my absolute, very clearly most favorite part of what I do. And part of the reason that it's so amazing is the collaborators, the people that I work with, and some of my favorites here, Angelina, Tony, and Dirk are on this call. Everybody is so inspirational in the work that they do and the quality of the work that they do and the care with which they bring to the work. I feel like I'm constantly growing and challenged and propelled forward in my collaborative work with this group. So I just wanted to say that out loud. So I am director of the Epilepsy and Neuropsychology program at DGNN. Importantly, I've directed the Duke Mbarara epilepsy collaboration, which has really been a phenomenal experience, because there are a lot of people on and a lot of students on both sides of the pond, as we say, that have contributed to our understanding of epilepsy care in Uganda, and areas of needed focus in moving forward. Much of my work in this area has been in trying to better understand the cultural context of epilepsy care, as we do infrastructure building or capacity building types of efforts. I think it is so important for us to really understand the culture of the space that we're working in, so that we can be respectful, but also very importantly, so that we can be effective. We are not going to be able to be helpful if we don't understand sort of the context of the work. And so we did a lot of initial work examining the barriers to epilepsy care. I think that Tony mentioned that. And in that work, we found out that logistical barriers and those related to actual and logistical costs associated with reaching care are amongst the biggest challenges for the public. For those 3 out of 4 people that don't reach care, those are some of the things that come up. But also much of what directs, we did some research looking at the sociocultural determinants of healthcare seeking and how people choose where they're going to go for help and who they're going to seek care from. And we learned an awful lot about how people think about epilepsy and the causation of the disease itself. And while I think everyone on this call would consider epilepsy a biological disease and one that is caused by disruption in the brain, in the larger community, in the public community in Africa, epilepsy is largely believed to be caused by either ancestral influences, possibly witchcraft, and sometimes demonic possession. So in order to be effective in changing how people seek care for epilepsy, we have to really understand that there's a large percentage of the population that not only does not think of this as a biological or mental health issue, instead they believe that it is one that is caused by other people cursing them, or the ancestors or demons possessing them. And epilepsy, because it's an intermittent movement-based disorder, very much lends itself to these kinds of beliefs that a person is temporarily possessed by someone else. And so then how people go about trying to cure that problem obviously is not by going to see Dr. Kakusa at the Malago Hospital, but instead by consulting with traditional healers in the community. So we've learned a lot about how people think about epilepsy, what some of the challenges to care are, and then what happens when they go to see a traditional healer and how that impacts their actually reaching biological care. And later on in the call, we can sort of elucidate what that journey typically or often looks like for the community. It's been absolutely fantastic to better understand our patient population, right? So that we can respectfully reach out to the communities, and also so that we can educate frontline health workers about how people think about epilepsy, so that they can also be sensitive in how they approach patients who come to clinic. And our work in that area continues. It's a rich body of literature. We just published a special issue of Epilepsy and Behavior that presents this work from front to back. And I think that's an important part of what we do as well, because it's important to be scholars and share the lessons that we learned with the greater scholarly community, so that it can hopefully inform lots of groups' work. So I think that's a broad introduction to the work that I lead. But really it's a collective effort amongst us all. Thank you.
Thank you so much, Deb. I'd like to kick off a more conversational segment of this panel right now. And Tony, I want to just return to you and follow up where Deb was talking about cultural awareness. Some of the terms you've used when we've been talking about this is humility, holistic care, allopathic care. Can we talk a little bit about your, work in Uganda and some of these topics?
Yeah, definitely. So I think that the first word that you said, humility, I think is probably the biggest and most important is making sure that you're coming to the situation with humility of the context, humility of the people that you're working with, and being able to really put yourself into the conversations, put yourself into the community to really understand. And I think that's exactly what Deb brought up, is that as we began to do a lot of this work, we were trying to approach this in as a very humble manner. So making sure that we identified as many people as possible who were already doing some of this work to understand what was already going on and what are some of the things that could still be done. In addition to doing that, I think also being able to just be present. And I think that's one of the things that I've been able to do as part of our team over the years, is just be in Uganda during a lot of the work. And so spending somewhere between 4 to 6 months a year living in Uganda to be around. So I'll just share a couple of things. So I'm an assistant professor and associate director of our group, but I love actually going out into the field and actually doing the work. And so being able to go out, and when we were doing our epilepsy prevalence study, we needed to go to all different parts of the country. And so part of what I was able to do in that role is actually be in Uganda during the time period of training, and then also be there during the time period where we're capturing a lot of the data. And what that allowed me to do is to really understand what were the issues that we were running into, what were some of the things that the supervisors who were helping to collect the data were running into. And a few different things that happened was things that just required me to not say, okay, hey, I am, not willing to go out or go on a boda or not willing to go in a car and go to this remote location. I'm willing to do that because it's necessary for what we're trying to do. It's necessary for, communicating with the community. And it's obviously necessary for the research that we were trying to do in order to ensure that we're getting the highest quality information before we make any decisions about that for the national level. And so I think from my perspective, it's that part of just being humble, not using kind of any title for what your position is supposed to be, and just showing up and doing what is necessary in order to make sure that collectively we're heading towards the goal and the mission that we're trying to do, which is ultimately improve care for epilepsy patients in Uganda. And whatever that takes, it is, for me, whatever that takes means that it is something that I'll be able to and willing to do. And I think that's the humility that we've approached it in, as well as ensuring that the loudest voices in the space should be the community that is impacted by epilepsy, and then the healthcare workers like Angelina, who are actually leading this work, because clearly most of the time we are here in the US, they're seeing these patients in clinic, they're dealing with these issues in the front line. And so being able to allow their voices to be the loudest when it comes to decisions about the research, come to decisions about what we're doing for clinical care, and then also setting the path for what we're going to do over the next 5 to 10 years.
Thank you. You had mentioned working with traditional healers and leaders. Can you tack on a little bit of information about that? Oh, and also I just mentioned any people in the audience who have questions, please put them in the chat. Thank you.
I'm going to pass this one to Deb because she did more of the traditional healer work.
Thanks, Tony. So I'm just going to tack on as I talk about the traditional healers, talking about the doing field work and having cultural humility. I think that I also have really enjoyed spending time in Uganda, although I don't spend as long as Dr. Fuller does. I have so enjoyed going to the country and spending time and working with my colleagues there, as well as seeing the beautiful country, and then going out and actually talking to the people that have been affected, from patients in the field that we've encountered, as well as the stakeholders in the field. And so important in doing work in this area is not only our allopathic colleagues in the biomedical space, but also going and talking to the people who are consulted and are considered by a large part of the community to be the experts, which are the traditional healers. And so when we began this work, we talked to all stakeholders, the psychiatrists and neurologists who actually care in the biomedical space, but we talked to patients and families, and we talked to the traditional healers, and we went out and talked to several groups, both in town hall types of meetings with the traditional healers, as well as small groups where we could more intimately learn about their beliefs. And it is really important to approach this from a place of cultural humility, of asking, of really being open to different ideas about what people believe and how people believe things should be approached and treated. And I have a colleague, Dr. Prose, that I work with on our current epilepsy frontline education project. And he always talks about cultural humility and emphatic curiosity, is that when we can come to people and really try to understand what they're saying rather than come leading with our own assumptions, we learn so much. About half of the people in Uganda that we talked with, when we talked with patients and families, and when we surveyed them as well, about 47% consulted, who eventually made it to biomedical care, first consulted with traditional healers, and almost another 10% first consulted with faith healers prior to eventually reaching biomedical care. And they consulted with them because in Uganda, whereas there's maybe one physician for every 20,000 people roughly, there is one traditional healer for every 200 to 400 people. And so there's the body of healers, traditional healers, is much larger and more accessible for those people who are in the community who can't necessarily get to a clinic very easily, and certainly not to a regional or national hospital. And so again, because so many people believe that epilepsy is caused by the ancestors, or that they've been struck by witchcraft or demons, they go to traditional healers, who are naturally looked at as the people who have the talent to interface between the current physical world and the spiritual world. And they are looked at as the negotiators and the people who can contact the ancestors. And so consultation with those traditional healers then have a consequence of people spending much time and many resources in trying to have their epilepsy resolved in this manner. And when we researched it, we found that the typical average delay to eventually reaching biomedical care, if one first consults the traditional healer or faith healer, is an average of a 2-year delay. So it's quite substantial, because in Uganda, there's not a lot of collaboration between the traditional healers and the allopathic biomedical care leader. So one of the things that we've talked about is trying to encourage more of a collaboration. And I believe that Parliament in Uganda about a year or two ago did pass a resolution trying to encourage registration and regulation of those healers. And so we can hope for more collaboration in that way. So that's, I think that introduces a little more. I'd invite Angelina to contribute and talk about this. Angelina, do you have any?
Oh, sorry. The issue of the issue of traditional healers has a sore point regarding the care. We had an issue, obstetric and gynecology care. When we realized, the Ministry of Health realized that actually many people are going towards these traditional healers as the first point of contact, the argument has been, Do we actually collaborate with them? Is there a way that we can try to co-opt them? The challenge is that not all of them are practicing the right thing or something that is less harmful to the patient. So there's still that argument on how far should the collaboration be between a traditional healer and the Western medication people. But with the traditional birth attendants, there's been some progress. Coming to epilepsy, that has been a bone of contention, because many times what happens with the traditional healers is that there are some that mix spiritualism as well as herbal medication. And then there are others who are purely herbal and they use certain herbs which do seem to work. When you tell them that would like to go further and study these herbs, they become a bit suspicious, which is understandable because they feel that you're going to take their rights, you're going to take their knowledge. So there's still that, I don't know, for lack of a better word, antipathy between the Western and the traditional regarding care for epilepsy, which still needs to be clearly ironed out. But the fact is, we cannot ignore them because people go to them as a first point of call. Over.
I'll also just add one more comment about this. Thank you, Angelina. We actually surveyed the general population, a national representative population of the entire country. And we found that, 2 out of 3 people have a pluralistic belief system where they believe not only in the potential of biological causes such as epilepsy from injury or illness or resulting from malaria or other biological factors, but also believe in these spiritual causes of epilepsy. So the vast majority of the population believes in both sources as potential causes of epilepsy. And so this is why it's so important that in any kind of infrastructure building or training of physicians and medical clinical officers and psychiatrists and nurses, that we understand that the population believes in this and that we are sensitive in our communication with our patients in order to make sure that they feel comfortable with the care that they are getting and will return for continued care, given that it is a chronic illness that requires constant engagement with biomedical care and medications to resolve.
Dirk, did you want to add something?
Well, I would like to mention 2 situations. First one is in Rwanda, where obviously the distance that people need to walk to medical care, biomedical care, is an average about 8 kilometers, whereby if they need to walk to the traditional healer, it is in less than 500 to 1 kilometer, 500 meters to 1 kilometer. So the choices for the people living in the villages is first indeed to go to the traditional healer. And then if we are smart enough to educate and help them, the traditional healers, understand that we can help the patients maybe jointly, then they can maybe refer and bring patients to the healthcare center. And we have done those exercises in northern Rwanda. And to our great surprise, after embracing the traditional healers as quote unquote partners in health, we were able to have them accompany the patients living with epilepsy to the healthcare center. And they were observing on how we were offering them care. And this allows us to give a better holistic care to the patients. And a second example I would like to give is that this is not only in Central Africa, it's not in Uganda and Rwanda, it's all over the place. And we were at a meeting with the Minister of Health in Mozambique, where we were talking about traditional healers. And we then posed a naive question and said, but how do you do when you have a common cold? And then she said herself, being a physician, that she would first consult a traditional healer. So the belief in the strength of the traditional healers is throughout the population, from the very rich to the very poor. And that is something that we as healthcare providers, both in the country and in support of the country, we need to be very humble about. There are patterns in the culture that we cannot change, but we can change the behavior of those people and make sure that they better understand what care is for people living with certain neurological conditions. Thank you.
Thank you. I wanted to next go back to Angelina to talk about access to medication and technology. Angelina, if you have some thoughts on, the differences between how that might be for a US patient versus a patient in Uganda.
Yes. Now, regarding access to medications, this is, of course, it's a very wide difference, because remember that in Uganda, the drugs that we have are over different, the majority of drugs that we have are over different generation. We have the first generation, second generation drugs, more than these other third, fourth generation drugs. And the drugs that are supposed to be freely available in the hospital, most of the times tend to have interruption in terms of supply, because they're ordered for and they're supposed to last always through the year, but then they tend to have a lot of drug stockouts. So you find that some months the patients will be able to have the drug, and then after some months there's sort of like a dry period where there are no drugs, and the patients who are able to afford have to go to the private sector to try and get these drugs. But remember that not everyone can afford these drugs. So what happens is that there is a bit of non-adherence, and with all the attending complications like going into status epilepticus and the others happen. So regarding a US patient and a Ugandan patient, the difference is very marked, because the availability of drugs is not constant. The types of medications are not constant. You'll find that the newer generation drugs are only accessed by those who are able to pay for it privately, going to a private pharmacy and being able to get it. But, otherwise, the other people who are not in a position to buy those drugs, even to buy the first, second generation drugs, are not able to access them. When it comes to technology, what technology is available for a patient with epilepsy? We find that the supportive investigations that we can do are things like an EEG. An EEG is not available free of charge. You've got to pay for it. At least in the clinic which I run, you have to pay a certain fee to be able to have the lady do the EEG on you. So that's an added cost. If you come as a patient who has epilepsy and you have to have that investigation, you've got to cater for that amount of money. Then if it comes to imaging, for example, if you have to do an MRI, it's only recently that we got an MRI in the hospital in Mulago where I work. But prior to that, we didn't have an MRI. And an MRI is something that is very expensive. Not everyone can afford it. It's not like a routine investigation that is done in the US when a patient walks in, you just run a battery of investigations and that's it. Even an investigation like that, you've got to start thinking, can they afford it? Will they be able to have the finances? So you find most of the times in our care, which of course is the standard, you have to do come up with a diagnosis clinically, and then use the few investigations that you can, what the patient can afford, like an EEG or an MRI. PET scans are not available, and any other investigations. For example, if you want to do a 24-hour or ambulatory EEG, there are some colleagues who are in another rural city sort of some distance from Kampala, maybe more than 200 kilometers, in a place called Mbale, where there's a cure hospital, where they can do a 24-hour video and video EEG, and maybe, if possible, do an ambulatory EEG. So you find that even the amenities for investigations are limited. So it's a challenge that we are faced with, but we try to live within the circumstances. Over.
And an EEG, Angelina, is an electroencephalogram. That's like a test for the brain electricity, right?
Yeah, it's an electroencephalogram. I beg your pardon. I just took it for granted. It's an electroencephalogram where they connect. There is a headset. They connect to detect the brain waves of the patient who's having epilepsy, and they're able to visualize. It usually runs over between 20 to 40 minutes, and they place the patient in this setup to try to see the abnormal waves, if there are any abnormal waves, or if there are anything that would be suggestive of epilepsy, like a spike and wave, or any focal spikes, or certain other abnormalities. So that's what they use to detect. But a normal EEG does not rule out that you don't have epilepsy. It's just a supportive investigation that we use.
Thank you.
So I'm just going to add two things to what Angelina just shared. So one about the medications and the other one about the imaging modalities. So I think one of the important contextual factors of treating epilepsy in locations like Uganda is some of the difficulties that Angelina brought up that arises from the stockouts. And so important in epilepsy care is having a full test of a medication to understand whether or not that medication actually is helping that person's epilepsy. So what that means is that someone is placed on a medication and they're meant to be at a particular dosage for a specific amount of time, and then ensure that that dosage is in the proper therapeutic range during that span before you can claim that that person is not able to respond to that medication. What it can end up happening is that either people are not on their medication for the entire time, don't take the appropriate dose, or when they come back to the hospital, there's a need to switch them. And so what you end up seeing more frequently in Uganda than you would see here is that you see patients on multiple anti-epileptic drugs, or that have tried multiple anti-epileptic drugs in the past. And so what that makes it very difficult to do is to understand, have they responded appropriately, or are they actually not responding to those medications? Something that we definitely see here when you're treating epilepsy is ensuring that someone, if they don't respond, then you put them on another medication. And the reason why this is important for our group is that part of our initial ideas when we're working in this space is that there's a significant number of patients who can be treated by epilepsy surgery. And so epilepsy surgery is actually a fundamental component of neurosurgical care. And so part of our residency training program in Uganda, our plan was to train more and more people to actually do epilepsy surgery. In order to do that, you need to ensure that someone has actually failed the standard of care from medication. But then, as Angelina also pointed out earlier, what you additionally need is ensuring that you have a focal location that you can say that that is where the seizures are originating from. And so that has to do with having an EEG. That also has to do with having some kind of imaging modality, usually an MRI, that allows you to identify that. And so all of that is also making it a little bit more challenging. One of the places that has done a little bit of this, as Angelina has brought up, is actually in Mbale at Cure Hospital, where they have done some epilepsy procedures where they do have some of those modalities present, the EEG, and then they use CT scans for making those decisions. But it's also part of what's important for our group as we talk about neurology and epilepsy, but then also how that translates to the neurosurgery side. So just wanted to bring that up.
And if I could piggyback on that, Tony, obviously, if access to medication is interrupted for patients in the field, that is water on the mill for traditional healers, because they will say, look, I can give you care, but you can't get the care in a continuous fashion at the health clinic. So that gives friction, and we need to be very well understanding that sometimes we walk in, offer a solution, but if we can't sustain the solution, we're doing more harm than we're doing good.
Thank you for those explanations. We only have 5 more minutes, so if anybody has questions, please remember to put them in the chat. One of the final topics that we're going to touch on is funding. You know, all of the things you're talking about, that the question of funding comes up. Does anybody want to start that conversation or just highlight some of the questions and issues surrounding funding?
Well, I'll just say that it's a challenge. I think that it's probably no different than the challenges of funding in any area, whether it's in global health or other. But there's, you know, I think there's the greater ethical challenge of beginning a line of research and work and partnerships to build hopefully sustainable approaches to epilepsy care, but also knowing that you know, having the funding to sustain the work is you know, is not a definite thing, and how challenging that is. We have been so incredibly grateful to the Department of Societal Responsibility at UCB, which largely funds our work. We are also trying to get some Fogarty funding with Dr. Kakusa in the lead of that initiative, as well as other foundations support to sustain, to ensure the sustainability of our work. The work that we're doing is even though there are scholarly products where we try to share our work, the primary objective is not research. The primary objective is research that expands care and direct care itself. You know, such as the opening of the Mbarara clinic that we, the dedicated epilepsy clinic that was, I think in the fall of 2019, that was launched. So there's limited, you know, there's limited opportunities. Fogarty grants are, you know, there's many needs that those limited funds cover. So it's our hope that this work can continue. It's challenging.
Now, our contribution, Debra, to the program is, of course, there's a financial contribution, but it is the energy and the participation of everyone in the team, being it our Ugandan colleagues, our US colleagues. And for those participants that are on this call, what you need to know is that there is an opportunity to embrace our social-cultural differences in an extraordinary way in Uganda. As Angelina was very vocal and very nice on illustrating how beautiful the country is on the flora and the fauna, the country is also extraordinarily beautiful in the people, because the generosity of the people, the helpfulness of the people is, for me, at my age of retirement, an extraordinary motivation to continue working. And I hope that we don't see on this call, that you feel the inspiration and that there is this opportunity that you can bring the scientific curiosity that you can bring to our team going forward and improving care, because it's a human right to have access to care. And I think Angelina is on the forefront of that. Debra is on the forefront, and Tony and Michael are, but we would like you to join us, because only with a united voice, we can do better things for patients living with neurological conditions in Uganda. Over.
Thank you. That was beautiful. we're hitting the end of our talk, and I wanted to thank everybody for being here today. I know your time is precious and some of you are on vacation. Thanks again. And for everybody listening, join us in a couple of weeks on April 14th for our Sustainable Energy and Health Think Global. It's our final one for the year. Thanks again. Take care.
Thank you for
Thank
having
you.
us.
Thank you.
Thank you,
Bye-bye.
Dirk and
Thank
Angelina,
you.
for joining.
Bye-bye.
Yeah.
Thank
Bye-bye,
you.
Angelina.
Bye, Angelina.
Bye-bye.
See you soon.
Sleep well in Uganda.
Yes, so thank you. Have a
Thanks.
good
Bye-bye.
day.
Yeah. Bye-bye.
Bye-bye.
Bye, all.